So I have the unenviable task of trying to teach you everything practical about diabetes technology in 15 minutes, so bear with me. All right, sorry, those are my disclosures. I have funding from Dexcom and Tandem, just to warn you. In terms of objectives for today, let's talk about the available technologies that we have that we can use for the management of CFRD. Think about the unique challenges of using these devices in our patients with CFRD. Think about strategies to leverage the benefits and burdens of these devices to use them practically and use them well. And then finally, think about what we know and what we don't know and really the need for future research. So just by way of quick summary, I know we're all familiar. Continuous glucose monitors, or CGMs, are wearable technologies that use a small subcutaneous sensor to detect and report interstitial glucose values to the user. We also have insulin pumps that use a small subcutaneous cannula to deliver constant rapid-acting insulin infusions. It's more closely mimicking physiologic insulin delivery than multiple daily injection therapy. And then finally, the latest technology that really combines the two, automated insulin delivery or hybrid closed loop, whatever you want to call it. But these systems use CGM to automatically titrate insulin delivery to optimize control. Starting off, in terms of what we know and what we don't know about CGM use in CFRD, we have very limited evidence. When you take a step back and you think about what we know in terms of other diabetes and how these devices are helpful, we know that we've seen improvements in glycemic control, improvements in treatment satisfaction, but the evidence in CFRD is limited. So first and foremost, we need to know that these devices are accurate. So there are several small-scale studies that have demonstrated the accuracy of CGM in people with CF who use that device. We also have some preliminary evidence that's already been addressed in the wonderful talks today. We do know that in individuals who have normal glucose tolerance on OGTT, that when they have worsening glycemic excursions, the maximum glucose value being up over 200, we know that we see worsening pulmonary function. So what you have here, this is a group of individuals that had normal glucose tolerance and were stratified into those who did and did not have maximum glucose values up over 200 in real-life CGM wear. And you can see that both FEV1 on the left and FVC on the right were better in the group that didn't have blood sugars over 200. We also know that when you use CGM to titrate and guide insulin delivery, that we see better outcomes. Obviously, that's a confounded study because we know insulin alone does that, but perhaps CGM also had a benefit there. So let's look at the international consensus guidelines for CGM use and time and range. In type 1 and type 2 diabetes, the general recommendation is that you shoot for 70% time and range, between 70 and 180 milligrams per deciliter, trying to minimize hypoglycemia with less than 5% time low. We don't have specific recommendations for CFRD with this. When you step back and when you think about what we do know with CFRD, we recommend an A1C less than 7. Again, we know the limitations of that and that it's really not specific to CFRD, but there's data to show that a 70% time in range is correlated to an A1C of 7. So arguably, I think many of us in clinical practice are using that time in range goal for those who are using CGM. The other things that CGM can be helpful for are what is specific to CFRD. So generally, we recommend fasting glucose values between 80 and 130, something that's readily visible with a CGM. And the real benefit here, I think, is in looking at the postprandial values. So we're targeting blood sugars under 180 2 hours after a meal. And the benefit of CGM is that you get to see that data without additional finger sticks. Another benefit to CGM is that not only do you get the actual real-time glucose value, but you also have a trend arrow that tells you where that glucose is heading in the next 15 to 30 minutes. What you have here, and something to be aware of from a practical perspective, there are 4 commonly used systems on the market right now. We have the Dexcom systems, we have Medtronic, we have Freestyle Libre, and then we also have Eversense, which is the implantable CGM. The trend arrows for all these different systems convey different rates of glucose change. And I'll show you why I'm pointing this out in just a minute. So what we know is that there's a lag time with CGM. The values that you're seeing are about 10 to 15 minutes behind what's actually happening in the blood. And that's because CGM is measuring interstitial glucose values rather than blood glucose values. So there's been an argument that we should take advantage of these trend arrows to better guide insulin delivery. So this figure here is really specific to the Dexcom system and the rate of change conveyed by those trend arrows. So by way of example, if you have a double up trend arrow, your blood sugar is rising by more than 3 points per minute. So in about 30 minutes, your blood sugar could be 90 points higher. And there have been several different guidelines published, largely in the Journal of the Endocrine Society. They're specific to each system. There's pediatric and adult versions. What I have here is a more practical, real-life example that I think is being increasingly used. So given the rate of change and predicting where that blood sugar will be in 30 minutes, the argument is that you can just add 90 points for a double up arrow to the existing blood sugar so that you can better correct for hyperglycemia. In terms of how long you need to wait after the last insulin dose, after the last meal, the guidelines have ranged anywhere from 2 to 4 hours. So typically I recommend 3 to my patients before they apply this rule, just because that's typically what we do with insulin dosing. In terms of other challenges with CGM use, we do know that there are interfering substances that can impact the accuracy. So specific to both the Dexcom and the Medtronic system, acetaminophen can cause false high values. In the Dexcom system, they do have an acetaminophen blocker. So if you're taking normal doses of acetaminophen, won't impact the accuracy. If you take supraphysiologic doses, it may. However, in the Medtronic system, any acetaminophen dose will cause an elevation. We have some research to say that it goes for up to about 10 to 12 hours. David Maas put out an interesting paper. It will impact it for a prolonged period, but really after about 6 hours, the typical dosing interval, we do see that you could probably use CGM again after taking acetaminophen. Other medications, typically not huge issues in CF, but we know that hydroxyurea can cause false highs with Dexcom. And then in the Libre, you can get false lows with aspirin, false highs with vitamin C. And it's interesting to keep in mind with vitamin C, it's so prevalent in foods, things like red peppers, commonly eaten foods, and that's why we don't yet have the ICGM distinction for the Libre as compared to the other systems. Another thing to think about in patients with CF, what about hypoxia? What does that do to accuracy? There's really no great studies getting at this. However, during COVID, the FDA has really turned a blind eye to the use of CGM for inpatient diabetes management. And with that, we're starting to see some interesting data. So there was one study, they looked at critically ill patients. There were a total of 24 of them. And they looked at the MARD, the mean absolute relative difference between the Dexcom and the fingerstick glucose values. And that MARD is calculated by measuring the difference between the two values and taking it as a percent. So the way that the Dexcom system was approved, it has an MARD of about 9.9%. In this study, MARD was 11.1%. In my opinion, not significantly different, which argues that it would be safe to use. Similarly, with the Medtronic system, which did require twice-a-day calibrations, the FDA approval MARD is 9%, and then it went up to 13.1% in the setting of critical illness. What I can't tell you here is how many of these patients were hypoxic. They didn't report on that. There was an illness severity score, but nothing really getting at the hypoxia. Other things to think about that are interesting here. So there have been studies where CGM has been used to guide insulin delivery. Specifically, one that comes to mind, Michael Agus did the half-pint study. And he used CGM to try to intensively control glucose values after cardiac surgeries. And in those patients, the CGM worked just fine. So I think we're starting to see more and more evidence that perhaps we can use it in the inpatient setting, including those who are hypoxic. Another thing to think about is radiation exposure, MRIs, things that our patients with CF are often needing and exposed to. When you put these devices on, you wear it for 10 to 14 days. You can't take it off and put it back on again. So each and every system on the market right now has a warning that it should not be exposed to X-ray, CT, MRI. But recent data has actually asked this question, is it safe? What can we do? So they took, it was a total of 48 Dexcoms, and they exposed them to very high dose radiation. It was a total of 80 grays. Just to put that in perspective, much, much higher than an X-ray dose or even a CT dose. MRI for me was the more interesting part of this study, so I would worry about the magnetic field, about dislodging it. So what they did when they exposed the sensors to the MRI, not only did they look at the accuracy of the systems before and after, but they also looked to see, did the sensor heat up? Did the sensor displace? So what they showed with all this radiation and magnetic field exposure, no impact on accuracy, and reassuringly, even with the MRI, none of the sensors were displaced. What I have next is a real-world survey. So a group of us through the Envision cohort with the support of the CF Foundation had asked patients on their perspectives. And what we had seen is that CGM use is high. About 75% of respondents with CFRD were using the system. The perceived benefits, which you can see on the top, were very high. And this is results from the CGM benefit and burden survey. People loved the system. 80% agreed or strongly agreed with the positive statements about CGM. However, about 1 in 5 patients stopped using CGM. And what I think is interesting to take away here is what were the burdens? Why did they stop? Cost is a huge issue. I think something that we need to do from an advocacy standpoint. We also saw concerns about pain with wear. That to me is interesting. It makes me wonder who's teaching these patients because typically it's a painless device. And then we also saw a lot of concerns about on-body presence, having a device attached. So I think these are things that we can target to better promote CGM uptake and sustained use. The evidence for insulin pump therapy is even more limited in the setting of CFRD. What we do know is that in those who started using insulin pumps, we saw improvements in body mass index and also in A1C in those who were using it as compared to MDI. We also have seen some very limited pilot data about the use of automated insulin delivery from our own Envision members, Jordan and Melissa. We've seen both single hormone, insulin only, and then we've also seen dual hormone with a combination of insulin and glucagon. So in a 3-patient study, the results looked very promising, and we'll be eager to hear more in the future. Practically, why are insulin pumps useful? We know that insulin requirements can vary drastically, as we just had a very nice discussion about. You can have multiple different profiles. You could have a sick profile and a well profile, a fasting profile, things that can really optimize control. And then we were also discussing challenges in terms of delayed gastric emptying. So you can do an extended bolus, where instead of giving the insulin all up front, you can deliver it over a more prolonged period. So no studies have really gotten at these, but I think these are some of the practical pieces that make insulin pump therapy nice. Coming back to that same survey that I had shared with you earlier, we also asked those with CFRD about pump use. Rates of use were much lower, so only 29% of those with CFRD reported pump use. 28% of them discontinued it. And here, as compared to 80% agreeing or strongly agreeing with positive statements about CGM, we saw that only 27% agreed or strongly agreed with positive statements about pumps. And when you look at the burdens, what bothered people about pump use, pain with wear was another common one, cost was a common one, and again, that on-body presence. So again, things that we can work on to address with our patients to help promote use, especially in this advancing era of automated insulin delivery. It's going to reduce the burden of CFRD, but only if we can convince people to use them. Practical questions, I don't have answers, but here are my questions. When do we introduce technologies? I've been very fortunate. I have good insurance coverage in DC. So as soon as someone has a diagnosis of CFRD, I use CGM to determine insulin therapy. That's before I've even started it, which is wonderful. Is that best practice? I don't know. Should we teach people finger sticks early? Something that I think we should try to better understand. And then thinking about education. So oftentimes in other types of diabetes, we do group education. You can't do in-person group education in those with CF. How can we do this better? Is it things like Attain Health, doing virtual education? Should we be doing app-based education? How do we support patients best? And then lastly, in this rapidly advancing era of diabetes technologies and automated insulin delivery, how do you keep it all straight? So this is a nice algorithm that came out of the Barbara Davis Center from Laura Messer, and it's CARES. So what it stands for is calculate. How does this automated insulin delivery system adjust the delivery? Adjust, what can the user adjust versus what the system handles automatically? Revert, when do you need to go from closed loop back to open loop so that the automatic system is not working? And then finally, just thinking about what are the key features about the system that we need to educate people about, what are the unique features of the sensors that work with each system, and then lastly, data sharing, which is a whole another conversation, particularly as a pediatrician with adolescent patients. So with that, what we have very limited evidence about technology use in CFRD. I think it's so exciting to hear from members of this group who are working to address it, getting some interesting and promising data. We know that CGM therapy is very positively regarded, but insulin pump therapy less so. And I think as clinicians, we need to think about the things that are beneficial and burdensome to our patients so that we can educate them best about how to do this. And then lastly, so much that we have left to learn. So I think as we get better evidence about these things, that will help with the advocacy piece with better insurance coverage to make these devices more accessible. With that, a huge thank you to everyone that's put this together, that's helped with all this exciting research. And lastly, if you go out to Glacier today, please do not push your slower moving friends to make them bear food. Thanks, guys.